So we'll go into our next presentation at this point, where we'll be discussing airway clearance in ALS. So that makes a lot of sense. We just talked about how swallowing can lead to safety issues with your airway. So that sets up our next speaker, Michael Brennan, very well. He is a clinical specialist for the Northeast region for Philips Respirotech. He's been with them since July of 2016. He's also a registered respiratory therapist that worked for UPMC Pinnacle Health in Harrisburg, Pennsylvania. Prior to joining Philips Respirotech, he worked primarily in the NICU, ICU, and CTICU in critical care settings and served as an adjunct faculty instructor for Harrisburg Area Community College within their respiratory program. He now travels throughout the Northeast, meeting with pulmonologists, respiratory therapy and nursing departments, case managers, Better Breathers clubs, hospital administrators, and staff, providing education on the importance of airway clearance therapy. He specializes in high-frequency chest compression and vest therapy, as well as mechanical insufflation, exsufflation, or cough assist. He is passionate about helping patients each and every day breathe a little easier through the benefits of airway clearance therapy. So please welcome Michael, and we'll have you share your screen.
Okay. Thank you, Jen. I appreciate that. And I appreciate you all being here today. Yes, coming to you guys from Harrisburg, Pennsylvania. So I'm going to get my screen up on the board here. Let's see. Here. Just want to make sure. And you guys, everybody's able to see that, Jen? So.
Yep, we're good. Go for it.
Okay, good. So just like my introduction, once again, Michael Brennan, registered respiratory therapist. I'm going to go over airway clearance with a focus on cough assist, or that mechanical insufflation, exhalation therapy that Jen mentioned in my introduction there. So I just wanted to kind of start out with that kind of physiology of airway clearance. And when I want you guys to think about airway clearance, I want you to think of it in two different separate but connected mechanisms. I want you to think of, that mucociliary clearance, or that movement of the mucus in your airways, and then cough clearance. So those two kind of separate, but they are connected. And when you think about the mucociliary clearance, I want you to kind of think of an escalator in your body, and down in your airways and your lungs. Basically, mucus is created, and then any kind of debris or irritant or things like that is swept through the lower airways of your respiratory system up into your central airway. And once it gets into that central airway, that's where the cough mechanism of the airway clearance, the two separate parts there, that's where the cough mechanism comes into place. So I wanted to go over, and I'm going to quickly turn on let me see my pointer here so maybe you guys can have that there. But I wanted to go over this illustration. This is kind of an artist rendition of what our respiratory system, our tract looks like. Down here in the big red part down here, that it's at the cellular level. They're called epithelial cells, and they line the entire tract of your respiratory system. And in those epithelial cells, there are other cells called goblet cells, and goblet cells are what produce and make our mucus. And all of us, every single day, we produce about 100 milliliters of mucus, just to be there to carry any kind of debris or anything out of our system. And we all cough it out, spit it out, or things like that. As you develop an infection or an irritation or something, your body wants to get something out and you want to be able to cough, those goblet cells kind of go to work and they start producing more mucus than that to get that stuff out. So there's disease states out there, such as COPD, and they kind of go hand in with a disease state called bronchiectasis, which is literally abnormal widening of the airways. So mucus kind of pools in those airways, and they constantly have irritants and things like that. So they're constantly trying to cough. Airways are wanting to constantly move that stuff out. And then other disease states right along hand in hand with that, like cystic fibrosis, they constantly have thicker secretions, and they aren't able to get all that stuff out without the use of some sort of device or percussion that will help get that out. So as that mucus sits down in there, it becomes very irritable. So just, to kind of keep that in mind with those goblet cells, when there's an irritation down there, it makes more mucus, and it can cause a lot of issue with other disease states while this is happening. So back to this picture here, as you can see that where I'm pointing, these black lines, they represent what they call cilia. And cilia are hair-like follicles that basically help sweep that mucus through your system and sweep it, with any kind of debris or anything like that. And I always, when I used to teach and tell my students, or when I'm out around educating about this, I always tell people, think of a wheat field. It's the best way to illustrate it. If you think of a wheat field with wind blowing back and forth, but it's moving extremely fast to sweep that stuff through. But that's the kind of motion that it does there. So that cilia, like I said, is what sweeps it from those lower airways up into those upper airways, and that mobilizes that mucus so that you're able to cough that stuff out. So that's kind of just what this illustration on this page is there for. So once it's swept up into those upper airways, then we need to think about that second part of airway clearance, and that is that cough. And this page here, it kind of goes into what is a cough, and it just states right here, it's a sudden reflex designed to clear the airways or throat of foreign particles, mucus, microbes, any kind of irritants. As we all know, a cough can be voluntary or involuntary. If an irritant is in our airway and our body wants to get that stuff out, we start coughing. We start having coughing fits, things like that, and that will continue to happen until the airways aren't being irritated. But our body also has the ability, if we feel we need to try to get something out, we can actually voluntarily cough as well. So both are there, and the thing to think about a cough is it's the primary vehicle to help prevent the spread of any kind of respiratory disease. Because if you're just letting that mucus and things sit down in there and you're not coughing it out and getting it out, it just becomes a breeding ground, a pool for pathogenic organisms, for infection and things like that to happen. And a weak or ineffective cough, so if you're not able to cough properly, it can leave you at a very high risk for that infection. As I said, if you're not getting that stuff out, it's a high risk for you getting those types of infections that will make you sick. I'd like to just point out this blue box down in here. When you think of neuromotor type diseases like ALS, there's a study in our state-of-the-art review in 2018 that airway clearance therapies and effective coughs together with severe bulbar dysfunction. So, some of the things that Paige was talking about in her talk there are the main causes of morbidity and mortality. So, kind of sickness and death in patients with neuromuscular disease. That hypoventilation and managing of secretions are some of the most important problems that these type of patients and yourself face on a daily basis with your disease. So, airway clearance becomes a very integral part of your disease process and therapy process. So on this slide as well, I always like to point this out. As Jen mentioned, I do this for Better Breathers Clubs, and that's a club for COPDers that they come together, and it's just strictly patients. And this is one of the things that I talk to them about as well, because a lot of the issues with their disease, they have issues, with cough, and their coughs become weakened and moving those secretions. A lot of those issues are in that beginning level, which I told you about, because the different disease state than ALS or neuromotor type of disease. So they use things like vest therapy, which I specialize in, which kind of percusses on their chest and helps move those secretions, so it's easier for them to cough. So it's a different type of therapy for them, to move those secretions. But when I talk to you about it, there is a mechanic to a cough, and a lot of times we don't think about it. When we're ready to cough, there's three different phases. The first phase is that inhalation phase. Without even thinking about it, we take a deep breath when our body's got that irritation and we're ready to, we want to try to cough, we want to try to get that stuff out. Our body does take a deep breath, and what that deep breath does is it fills our lungs with that air that we're trying to pull in, and a lot of times it will take it to almost, max lung capacity. And what happens, it goes into that second phase after we take that deep breath in. And basically your glottis, your vocal cords up in here, they will close shut, and all that air is in there, and it creates a pressure, and it's called a, intrapulmonary pressure, but it's also like a pressure gradient. So once it reaches that pressure, a shift happens, and when that shift happens, our vocal cords will open back up, our glottis there, and all that air will rush out, and that creates that cough and the movement of the diaphragm, and it all works together to help move that cough and help push that mucus out. And that's moving us into that expulsive phase. And that expulsive phase is basically the release of that air through those vocal cords once that kind of pressure shifts in our thoracic cavity, and when we want to able to push that through. So that expulsion can be measured in a strength. It's called your cough strength, and it's typically referred to as peak cough flow. And if you've ever done one, or if you haven't, there's devices out there that are called peak cough flow meters, and it basically measures that strength. And typically, a normal cough is around 360 to 1,000 liters per minute. And to give you guys an idea, I this is how I explain it to my students when I used to teach them, is it's really fast. And I know that we're not going to interact here or anything. I wouldn't ask you to jump off mute or anything if you had the answer, but I always threw this out to my students: what's faster, a cough or a sneeze? And I usually did get cough, because if you think about it, they start thinking about it, your mouth is bigger, it's more space. But to give you guys an idea, a cough can travel up to 50 miles per hour, and can create about 3,000 droplets when you cough. But a sneeze can travel up to 100 miles per hour and create almost 100,000 droplets. So a sneeze is definitely faster than a cough, and can create a lot more droplets when it happens. And I don't have all the research and the answers as to why that is. I mean, if anybody does, please jump in here. But that is a very interesting fact to understand, that, and especially in today's society where now we're having to wear masks and things, there's a reason they want it over our nose. It's that 100,000 droplets, and versus a cough is around 3,000 droplets. So it's a very interesting fact to understand, and to give you kind of a gauge of what is 360 liters to 1,000 liters per minute even mean. It means 50 miles, up to 50 miles per hour, if you think of that. And for a sneeze of 1,000 miles, or 100 miles per hour, I'm sorry. So just kind of give you that gauge of what that liters per minute even means. So this next slide here is, I just put up here, kind of that graph to give you guys an idea of the parameters that clinicians look at when they're looking at a strength of a cough. When you do that, kind of peak flow meter, and it gives them that strength of a cough, it's kind of the parameters that we look like. And as I said, I'll start down here at the bottom. Remember, I told you that peak cough flow from greater than 360 liters per minute up to 1,000 liters per minute, that we consider that an effective, stable cough at that point. There's been no weakening to the cough, and a lot of times, a disease might not be diagnosed at that point, or things like that. That's a patient that has an effective cough. And then once it starts dropping, when you get into this level of a 270 liters per minute to 360 liters per minute, and it's measured on that little device, we start to recognize that's a mild impaired cough. They've got some low risk of having issues, respiratory issues, because of their cough. And then as it gets even lower, as we're measuring on that device, as we're looking at 162.70, that's a weak cough. Again, it just higher your risk of having a respiratory issue or disease, or what potential problems could be coming down the road. And once you get below that 160 liters per minute, we classify it as no functional cough. So you're not able to move the secretions correctly. You're at very high risk of constant respiratory infections and things like that. So just to give you guys an idea, when we take a look at these measurements, that is what we're looking at as we do it there. And remember, like once again, these measurements, if you think of speeds and things of like that, as the peak flow goes lower and lower, the lower the speed of being able to put the mucus out, or cough those irritants, or any kind of debris out of your system. So some conditions where cough may be impaired, and it comes into, I talked a little bit. I'm not gonna stress in this talk, things of COPD patients, bronchiectasis, cystic fibrosis. Those are separate disease to say. But as we go into another one of the big reasons cough can be impaired is neuromuscular diseases like ALS, muscular dystrophy, spinal muscular atrophy, any kind of disease where the respiratory muscles become weakened, causing that atrophy, or kind of wasting away, or muscles becoming smaller, and loss of effectiveness of muscles. So as even Paige brought up a little bit, as those bulbar muscles weaken and things like that, it becomes more difficult to cough. It becomes more difficult to move those secretions. So in certain cases, and as it progresses, different therapies are out there to help facilitate that. Another one is a spinal cord injury. There's supposed to, it's a greater degree of dysfunction. Obviously, the nerves with the spinal cord, it's not functioning correctly as far as allowing the body to cough and things like that. And this just kind of gives a comparison of that neuromuscular versus pulmonary diseases. Once again, neuromuscular destruction of motor neurons, gene mutations, ability to form, maintain that healthy muscles, as once again found in muscular dystrophy. And in a lot of times, it's not a disease of the pulmonary system. A lot of the times, is what I'm trying to say, is normal mucosal function is found, normal lung tissue, alveoli, non-diseased airways, and those things may only become damaged as a result of weakening muscles and things like that, and not moving that mucus out and things like that. But it's not, directly, pulmonary disease, unless a patient's presenting with, some other comorbidity or other type of disease state. And once again, up here on the side here, it just kind of goes into the, different types of disease states, giving that definition of respiratory muscles weakening over time. The muscles become smaller, atrophy, things like that, spinal cord, that denervation of ventilatory muscles, decrease inspiratory capacity, expiratory muscle force, so that everything becomes effective. And this is where cough becomes impaired in these type of disease states. So I pulled this out here, of our profile. I know all of you. I do not have to educate you at all on your disease states. I work directly with cystic fibrosis, and some of the most educated patients about what's going on with them and things like that are both ALS and cystic fibrosis patients. Really their disease state and understanding. I just put this up on here because this kind of just, once again, it goes into detail of where a cough and where respiratory issues may come about within the ALS patient, and a lot of it has to do with that. When that diaphragmatic weakness starts happening, the diaphragm's a muscle. It starts to weaken at certain points. It causes things like that increasing shortness of breath, that fatigue, that with exertion, that being tired. It's because your body's really working to just do that breathing. Declining in performance in athletes without underlying pulmonary diseases, inability to wean from mechanical ventilation, so inability to get off that ventilator without any kind of identification of another pulmonary disease that might be going on. So that these fall into place in ALS patients, along with that bulbar muscle weakness, the changes in voice quality, slurred or thick speech, decreased voice projection, drooling, choking on dry and crumbly foods or thin liquids. That becomes an aspiration risk, becomes, a choking risk, things like that. Rigid or lax muscles of face, jaw, lips, and mouth. These are issues where, as we said, this type of disease with ALS, that it can affect everything that's going on with secretion movement, being able to cough, being able to move that stuff out of your respiratory system. So this kind of comes into what I really wanted to talk about, and it's that cough assist, that kind of mechanical insufflation exsufflation. And one of the big myths about it, if you've ever heard of it before, or you've actually used it, or if your doctor or nurse starts to talk to you about it, one of the big myths that I really want to dispel is it is not just to move and pull those secretions. The cough assist and mechanical insulation, the whole machine is designed basically to augment that cough. And remember, that cough is very important. It's very important to keep that cough strength moving. And if it's not there, to have a machine that will help facilitate that. And it's very important in preventing respiratory disease, because remember, I said, if that mucus just sits down in there, it becomes a pooling ground and a breeding ground for pathogenic organisms, and it just is there. And patients that don't get that stuff out are constantly getting reoccurring infections, and that's when you're getting sick. Cough assist, mechanical insufflation is a strategy of trying to prevent that. Now, when you become sick, the strategy becomes a little bit different. And I'll go through that towards the end here of different settings that we have on our machine. But once you become sick with an infection, the strategy does become a little bit different. Then yes, we're augmenting that cough, but we are focusing on getting that secretion movement out. But for the most part, when you do this kind of therapy, it is a preventative type therapy. We are trying to just keep that mucus kind of moving through the system, keeping those airways, patent and open and strengthened and things like that. So this kind of graph here, I just really, we put it together because this picture in the middle here, that's what our cough assist machine looks like at Philips. And we're both Respironics, and I'm on the side of Respirtech, which is their airway clearance. We have both vest therapy and cough assist, but this is kind of what that machine will look like if you're ever prescribed it, or if you've seen it or used it. This is the newest version. I know some places I've seen it where they've got older versions, but just to give you an idea of what it would look like. But this graph here kind of goes into that. I want you to really think of it as cough augmentation. It is created to help facilitate that cough. And that leads to mobilizing and clearing secretions. So it's not just, hey, this is going to pull my secretions out. That cough augmentation leads to mobilizing and clearing secretions. Because if you didn't have any kind of disease state going on and your cough was normal, the cough would be able to just do that for you, and it takes that stuff out. So once that becomes an issue, and as the disease state progresses, this is the type of device that's going to help continue just to have that functioning strong cough. And then that once again leads to that preventing lung infections. We get that mucus out, and it also, a part of our protocol is we do lung volume recruitment, which is nice deep breaths, and what we're trying to do. But even the cough therapy, just by putting that air into your system and then taking the air out, with a therapy, just like a cough, it fills your lungs with air, and then it goes to a mode where it pulls that air out, and that's that whole pressure gradient. It just changes that. It shifts into that expulsion. Well, that whole air helps prevent things like atelectasis, your lungs consolidating, which can make it harder to breathe, and it can open up things once again for infections and sickness. So by doing this type of therapy on a daily basis, these are things we're trying to prevent, and these are the things that we're trying to help. And this is, can be a very effective therapy, especially for ALS patients. And it's not just when, what we try to stress with physicians and things like that, and patients as well. It's not just when you no longer have a cough. We want to try to catch it early to help keep that cough strength there, and keep preventing those infections, and working with you. So, that's why we say it's not just a secretion clearance mechanism. It is a cough augmentation mechanism. So, this is just a picture here. It gives an idea. It's kind of a tubing that will come off the machine. It can be through a mask, and it also can be through a mouthpiece. It can hook directly up to a trach. So I just wanted to kind of put this in here, but it also goes into mechanical insulation exhalation therapy has been clinically proven to increase peak cough expiratory flows, reduce those recurrent infections. We've seen results where as early on stages of this that we've seen improved peak cough flow. And it's something us as a company, I know that we are doing is a cough flow meter is sent to you and your caregiver, and we're monitoring these type of things to try to see those improvements. Sometimes it depends. Every patient's going to be different. Sometimes we do see those improvements, sometimes we don't. There have been clinical studies that they do show improvements, but we are definitely monitoring that and taking a look at that, because we want to, if we can catch it early enough, we can maybe improve those cough therapy flows. We can, by doing these type of exercises, doing these type of therapies with our patients. Another studies that are out there is that patients prefer this type of therapy, mechanical insulation exhalation therapy, to suctioning. Number one, for comfort, effectiveness, and to reduce fatigue. And this comes in a situation where, yes, a lot of times these are done hand in hand, but when it comes to it, on a daily preventative type routine basis, this can help with those type of things. And the thing to bear in mind with suctioning, if you understand your lung anatomy, your central airway rides right down here, and I know this isn't the greatest picture of it, but there's something called bifurcation of the airways, and it splits right here in the middle at your carina. It's called there. It's right there in the middle between your lungs. It splits right there, and if you just look at this picture and follow my pointer, the natural curve is just to go straight into that right lung. It takes a lot to get it to come back into this left lung. So even when suctioning is happening, 90% of the time, it's just going down into that right lung, and it's not getting into that left lung. So it's just something to bear in mind with suctioning. And MIE, mechanical insulation exhalation type of therapies. It's 89% faster than suctioning, 78% more convenient, 72% more effective. Once again, with the MIE, you're pulling from both lungs, both airways every single time, where suctioning only a very small bit of the time are you getting down into that left airway. So when it comes into things like suctioning, it's something to really think about. But I also want you to bear in mind that sometimes MIE therapy is done in conjunction with suctioning as well. So they're both being done at the same time. And this here, once again, gives a kind of illustration of the tube being hooked up to the machine there. This is what it's going to look like. This type of therapy is most of the time wanting to do it that sitting up position, and straight ahead looking there. Once again, it all comes down to how we want to set it up to make it most effective to move that stuff through your system. But what this slide also goes into is that kind of lung volume recruitment. It basically, at the end of our therapies, we set up this little machine here. It's got 3 different therapies that we can set up on 3 different settings, and we send the person out to your house with a caregiver that's going to go through all this stuff and with your caregiver or yourself, so that you understand how to easily go through, and it's just a couple buttons to push through this therapy. But basically, the first is your cough therapy. We determine what centimeters of water of pressure that is most effective for you, and we set it at centimeters of water pressure, and that's basically how much air is being pushed into your system. And then we set it at a centimeters of water for when that pressure gradient changes. Remember, we fill your air with lung, and then we set it to a negative centimeters of water. So, for example, let's say we do 40 centimeters of water to push air in. We push that in, and then we'll set it to a negative 40 centimeters of water to pull that air out. So basically, the machine, and the reason there's some misconception is because the machine you think it acts like a vacuum cleaner, but what it's really doing is creating that pressure gradient. But what happens is air comes in, so you're lungs fill out, and then air is pulled out. And it's and we also teach you during that to work to open glottis, or it just do that. You do that cough as the air is being pulled out. You're trying to do that cough, and it takes some coaching and it takes a little getting used to. But most of our patients, once they're able to work with it and become comfortable with it, it's a very effective therapy. So once again, back to three different settings. That first setting is just your cough therapy. And then setting two is when you're not feeling the greatest, when you're having an infection. We kind of manipulate the settings a little bit. It's a little bit higher, settings to help really move those secretions and pull those out. So we teach your caregivers and yourself that, hey, when you're having an infection, things like this, once again, that strategy becomes different. We really want to make sure we're getting all those secretions out and really working to do that for you. And then the third setting that we put in is that lung volume recruitment, and it's basically just deep breaths with our patients. They do this therapy several times a day. Usually, each therapy session's about 4 to 5 coughs. So 4 to 5 filling your air in and out. Your lungs in and out with that air. And doing it 2 to 4 times a day usually is typically the protocols that are set by your physicians and things like that. But when they're doing this, at the end of those cough therapies, we are putting that setting in that is called lung volume recruitment. So it'll be one more button that your caregiver or yourself will push. It'll go to that third setting. And we teach you to do this at the end of each therapy. And it's just nice deep breaths. Instead of that negative pressure, which creates that cough, we just do a positive pressure. And they work. What's effective for you? What's effective for your lungs, what's comfortable, what you're able to tolerate. We fill those lungs up and then let you just naturally take a nice breath out. But the whole idea behind it is keeping those airways open, hopefully preventing that consolidation, lung atelectasis. Um, you know, and it is some work. And again, I agree with Paige and Jen. At certain points, we don't want to exercise your lungs to the point of where you're doing more damage. There becomes progressions in your disease state. But caught very early on, this can be an effective therapy to hope maybe prolong getting to that point. So caught a little earlier on, doing these type of breathing exercises can be effective with this type of machine. But yes, it's something that we're doing at the end of each therapy. Patient tolerated, as long as the patient can tolerate it, just to kind of take those nice deep breaths, to help keep those airways open and strengthen there. So we continue to expand on Respirtech. Like I said, if the big company Philips that you might think about, that's where I do work. But Respirtech, we are their airway clearance division. Like I said, we have vest therapy and cough assist. And then if you think of Respironics, is your Trilogy ventilators. If you have one or you've seen one or used one, and they do things like sleep and respiratory there. And then they've got a whole other division which is like their toothbrushes and all that good stuff. So that's kind of how we fit. But Respirtech, we are very much focused on airway clearance and focusing on complex respiratory conditions to help do that. And this gives a good, nice illustration of how that mask fits on during this therapy and how you work with it to do each therapy session. And again, this brings up those three customizable modes. I won't spend too much time on it here, but and things like that. We do things like titration with it, clinical monitoring. There's an SD card in it that you can send information back to your doctor that will basically give them an idea of what's going on. Is therapy effective? Are you using it? Other things that could be monitored is peak clot flow can be monitored on this machine, tidal volumes, so basically how much air is getting into your lung, and that SpO2 level, so your oxygen level in your blood can be monitored used as well. So it's very portable. It has a battery, so it can travel around. But just to give you an idea of what this machine looks like for this mechanical insulation exhalation type therapy that is out there for neuromuscular patients mainly. And it goes into, this is kind of those required coverages. I know it's a lot up here on the screen, but things like here that I do want to go over. Jen had asked me to bring up some certain things that I see and that we see as our company of how to get this covered. How to go through about this. Some of the things. One of the qualifying diagnosis, and the diagnosis is these are all Medicare codes. They're all listed here. Documentation in a medical record that the condition is causing a significant impairment of chest wall or diaphragmatic movement and results in an inability to clear retained secretions, and a face-to-face exam or written order prior to delivery of the device. So just understand that this is what Medicare and insurance companies look at, that has to be filled out by your doctor, to get this type of therapy approved. There also are exceptions, and once again, I work with a company that this is all we do. We don't have a million different products. We have best therapy for cystic fibrosis and COPD kids, and we have Cough Assist. So we have a whole clinical team that really goes to work for patients, and that's something that I take a lot of pride in, and why I'm very proud of this company is we take a lot of pride in helping get patients the therapies that they need. So don't ever think that you know just it's just a black and white if it's not in this type of, if it doesn't fall into any of these categories or things like that therapy is just an impossibility. It's something that we really go to work to with insurance companies, getting doctors to have phone calls with them, explaining medical need, things like that. So I always stress that, if it's a therapy that the patient really needs, we work our hardest to get it to you, in any way we can, and get it covered by insurance. This sheet has in here contraindications for cough assist or mechanical insulation exhalation, any kind of history of bolus emphysema, which is an emphysema that basically the air sacs in your lungs are really enlarged, and they're at risk for rupture. So putting a bunch of air in there may not be the best idea. So it's kind of a contraindication of that, where it should not be used. Known susceptibility to any kind of pneumothorax, where air enters the space in between the airways, like the little alveoli in the lungs, and it causes the lungs to collapse. If they've had known susceptibility to that, this might not be the best therapy, because, well, again, you're putting a lot of air in there to pull it out. Or any kind of recent barotrauma to the lungs, so any kind of lungs that was caused by excessive air pressure. Those are the three main things that, if we see a patient that's had these type of issues, that this might be not be the best therapy for them. We might have to try to look at other things to help them, mobilize secretions, or work with them, in creating that cough and things. Some patient selection criteria. This is directly from our internal team, that I wanted to put up with here. That I went into our internal team, and I wanted to be able to present to ALS patients directly. Some of the things that we look at, and this is presence of these symptoms may suggest that a patient could benefit from mechanical insulation exhalation therapy. A weakening or effective cough due to immobility or diaphragmatic weakness, which can result in a high risk for developing atelectasis or pneumonia. Hyperventilation with a need for secretion management and cough reflux augmentation assistance. Lack of glottis control and bulbar dysfunction, difficulty or inability to clear secretions from airways, or may have tried and failed other airway clearance techniques. So these are things that I wanted to put up here, that, these are things that can be spoken to about your doctor, that can be put into notes. If for some reason there's some friction or coming back with insurance companies of getting this type of therapy approved. Again, we really do work with the doctors, and if they're able to show us data, or put in their notes, or things of these type of nature, of what is going on, and give a better picture to the insurance company of exactly what's going on, to help get this type of therapy to the right patients that need it. And then, again, I really wanted to pull out this, but it goes into air conditions associated with airway secretion clearance needs, goes into the different disease states that are out there, with ALS being right at the top, and it'd be, because of that progressive muscle weakness, this is a type of therapy, because I get a lot of questions, from both patients and especially healthcare teams, like, like respiratory therapists and nurses in hospitals, of which is the best therapy for an ALS patient. And would it be vest therapy if they've still got kind of that effective cough, or would it be cough assist? That mechanical insulation exhalation. My answer has always been with an ALS patient is it's going to progress, and I would much rather get them on the cough assist, which, as I said in the beginning, it can be beneficial to you know be able to work those airways a little bit to help move those secretions constantly and to help that keep that cough strengthened. It can be beneficial to do so. So I would always suggest for an ALS patient cough assist, whether bulbar muscle weakness is fully taken in effect, or a cough has become completely ineffective through their peak cough flow meters. I would always suggest a cough assist, because insurance companies, they look at vest therapy and cough assist as what they call same and similar, and if you get one, it can be difficult to get the other. So I would always suggest, obviously it comes down to doctor discretion. If your doctor decides that maybe a vest would work for you best, we kind of have to go with that. I would always kind of say, hey, maybe get a second opinion on that, because again, cough assist as it progresses is probably going to be the more beneficial therapy for you to have as your disease state progresses and goes along. And that's everything, Jen. I just wanted to put those last couple slides up there for that, but I can stop sharing my screen here. And if there's any questions, I'll be glad to stick on here and definitely answer them.
Well, thank you so much, Michael, for your wonderful presentation. You really went over a lot of the different, respiratory techniques and equipment that is needed for an individual living with ALS. So we sincerely appreciate you going through this so thoroughly. So I think you might have answered some of these questions already in your last few slides. One of the questions relating to insurance and covering the cough assist machine. I do know that out of that question anyways, that there are some folks who would want to try to get the cough assist machine earlier than insurance will cover it. Do you have any suggestions around that?
Yes, again, it's going to be a situation where we may have to get your doctor involved, and there's not only with insurance companies, it can be difficult sometimes, but there are so many studies out there showing how this can be so beneficial. And getting, the biggest thing I think would be is getting their doctor involved, and getting them to get on the phone with the insurance company, which is something that we do all the time. So with our company, and Phil, I can tell you, we're going to go to bat for you to get that done. So and if it's not happening for you, it's definitely a question. Hey, has my doctor talked to the insurance company? Because a lot of times them getting on the phone and explaining the situation of where they're coming from, of why they're prescribing this, can be immensely beneficial to getting the therapy approved. So
great, wonderful recommendations, thank you. Do you believe body positioning affects PCF, like sitting versus laying down?
Yes, definitely want to try to be as upright as you can be while doing that. And it's just simply of just gravity and body. We want to make sure that, and kind of just thinking about that head straight forward. It's almost like we want you to give your best effort. So we want to get you in a position where, whether you're sitting or as upright as you can be, and head straight forward, that you're giving that best effort, because we truly want a real measure of what that, and if it could be very different if you're just laying down and not getting that best effort, because you're going to get a very different reading, and that's not going to be beneficial to you or anybody on how we can set up your therapy and things like that. So yeah, I definitely say sitting up if you can.
Let's see. Is the in and out pressure usually the same?
Okay, with us, I can tell you yes. And there are reasons for that. There are studies that Philips is involved in, and a lot of different really interesting protocols that are coming out with Cough Assist and the things that we're doing with it. It is usually, but there are situations where doctors and we're trying to work with them on this because they still view it as a vacuum cleaner. Well, they will set the negative pressure higher than the inhale pressure. And the reasons for that is, once again, in their theory, okay, I'm going to put this much in and then I'm going to really pull that stuff out. So it's going to be a lot more of that negative pressure. And things that we're showing and things that we monitor at Philips is upper airway collapse. And as you understand, with bulbar weakness, that becomes even more riskier. And we really want to prevent that upper airway collapse. And if you think about it, if you're pulling more out and you continue pulling, it is more risk for that airway to eventually close as you keep pulling air out. So what I can tell you is, we will definitely, in the end, there are physicians that believe that there's different schooling, but we will definitely, come back to a physician with our data information explaining that setting shouldn't be that way. That's not how this machine works. So you will see it, but I will tell you, we don't believe here that that's the way it should be set up. So. Again, it's cough augmentation. Don't think of it as a vacuum cleaner for your secretions. If I can get anybody to come away from this with anything, I really want you to think of it that way. It's to create a cough.
I'm going to butcher this. I can't even say that. I'm sorry. Atelectasis.
Atelectasis, yeah.
Reversible with this treatment. Why can O2 stat stay in the 90s?
Adequate, is it reversible? It's definitely going to atelectasis. I mean, it can be reversed. It just basically it's consolidation of your lungs. And once again, if you're taking nice deep breaths, you're going to pop those lungs open, and you also have a machine that's kind of augmenting that air. I teach my children when they're feeling sick. When you have an infection, I will tell all of you, when you have an infection, don't forget to take deep breaths if you're able, and because if you're just taking those little guppy breaths, that's when atelectasis occurs, and that your lungs consolidate and it becomes harder and harder to breathe, because if you think all your alveoli just kind of scrunch in, it makes it harder to move that air through there. So it makes it harder to breathe. So yes, with this type of machine, it's going to definitely help. Completely 100% reverse it, I won't sit here and say that yes it will, but it can definitely help, and it can definitely help pop some of those airways open. The second part, I guess that's
why can O2 stat stay in the 90s?
That can be a variety of different situations. I mean, what I can tell you as an RT, for any kind of patient, as long as you're satting above that 92, 90 to 92, it's not something that we would concern ourselves too much with. Why they stay in the 90s, that's what it goes kind of back to that. I guess maybe if there's further clarification, but I truly believe if you're satting that 90 to 92, it's not anything where we become very, very concerned with. Once it gets below that 90, that's when it becomes a concern. But it could be a variety of different reasons. It could just be blood flow. It could be a lot of different things of why maybe it stays in those lower 90s. Along with just simple breathing. Is there other things going on keeping it there? So.
And the last two questions it looks like we have, what alterations can you perform to help people with bulbar issues who struggle to tolerate cough assist? Could be due to flexidity or spasticity in the pharynx and larynx.
As far as augmentation, those are things where we're going to work with different pressures. Once they have that bulbar issue, we're going to work with different pressures and different basically inhalation times, maybe to work with them, with those type of issues. It will definitely, somebody that's not having those type of issues will have different settings than somebody that would. So those are some of the things that we'll do with the machine to work with that, to try to kind of make it so it's more comfortable, it's more effective, and keeping that stuff going on. But yeah, it definitely can be worked with. It will definitely be different settings as we're monitoring that, than what somebody that's not having that going on would have. So the machine's pretty flexible.
Thank you. And the last question, how do you prevent air going into the stomach? I've had patients complain of this. I suspect the pressure is too high. Is this correct?
And that was my exact answer. Yes, sometimes the pressures can be at the wrong places, and it's also working with the patient. Working on glottic opening and closing, things like that, so that their vocal cords in there. Working with them on that. Again, I stress to all of you, if you haven't done this type of therapy and you're thinking about it, it's a therapy. It takes a little bit of getting used to, and we really work with you to do that. But yeah. They hit the nail on the head. A lot of times it can just be too much pressure. And the nice thing I can say about the Philips Cough Assist is we have something called it's called Cough Track, and basically you initiate the therapy. There are other machines out there and they don't have that on there, so basically it's on a timer, and your caregiver yourself will just put it on and it will just start. Well, ours does not start until you trigger it. So when you start to take a deep breath, ours will start. So it starts when you're ready. So it's a little easier to kind of coach you into that. It will start when you're ready, so you're able to work with that glottis and hopefully not have it going down the stomach. But yeah, it is something that occurs a lot and can be fixed with the pressure settings, and then just coaching on that. So
we did have one more question come
Okay.
in. Is 5 reps 5 times normal with Cough Assist with ALS, twice a day?
Yes, that's about right, because it's usually about 20 to 25 coughs that we like to get per day. When I was throwing those numbers out, like I said, I'm going through very generic settings. I always tell folks every single patient's going to be different. So you're doing it twice a day, 5 times. You're getting, or that you're getting, and through those cough sessions, I'd have to see it, but I'm assuming. But usually it's between that 10 to 25 coughs per day. That's why I said, we set it up usually maybe 4 times a day, and they'll do four coughs each time. So there's 20. So yeah, if your doctor has prescribed that, that's pretty typical. I mean, as long as they're in between that, 10 to 20, 25 coughs per day, you're right in that range. So.
Any other last questions for Michael? Well, we thank you so much, Michael, for spending your Saturday afternoon with us and providing such helpful information. We sincerely appreciate it. This was wonderful, so thank you.
Thank you, guys. I appreciate it.